Okay, well, welcome. We are on the respiratory system. Let me share my PowerPoint with you. Big functions of the respiratory system. Gas exchange, that's probably the biggest function that would come to mind. We're going to be able to allow oxygen to diffuse into the bloodstream and to allow carbon dioxide to diffuse in the opposite direction into the alveoli so we can exhale it away. But it has a big function in regulation of blood pH. We'll talk about the effect of carbon dioxide on pH. Big topic, especially for you guys going into nursing and the PAs, people that want to become PAs or ultimately nurse practitioners. You have to become rather fluent in blood pH and the different things that affect it, what's called acidosis and alkalosis. Vocalization, you vocalize or you produce speech as you exhale. And that, remember, along that pathway, there are olfactory receptors that help you detect the different odorants in the air as you breathe in and out. All right, so the gross anatomy, we have the upper respiratory tract and the lower respiratory tract. The nose and the pharynx, which is essentially your throat, constitutes the upper respiratory tract. And then anything, once you get to the larynx, and your Adam's apple, all the way down, that's all part of lower respiratory tract. The larynx, trachea, bronchi, and lungs. So here in this diagram, we have, if we follow the pathway of air entering the body through the nasal cavities and even in the oral cavity, you have the pharynx, of which there are 3 areas. We'll talk about that. And once you get to the larynx there, then that becomes the lower respiratory tract. Trachea in the middle. Trachea transports air into the chest. The bronchi, right and left, transport air into the lungs, and it branches off to smaller structures called alveoli. So nose functions, we're going to start at that point where air enters, and we're going to go structure by structure, functions, and so forth. All right, so nose functions. Well, provides an airway for respiration, moistens and warms air because of the type of tissue that's found there, that pseudostratified ciliated columnar epithelial tissue. Has a lot of mucus on the surface, so it helps to moisten and warm the air, and that mucus also helps to filter and cleanse the air. In these regions, we have olfactory receptors, and it adds voice resonance. The nose is composed of your external nares, they're called, when your nostrils, as they flare, sometimes as you breathe in and out. We have the nasal cavities, or internal nose, contains hairs, for filtration, blood vessels for warming the air, mucus glands for trapping debris and killing microbes and moistening the air. The tissue found there is pseudostratified, ciliated columnar epithelium with many goblet cells stuffed in between. And then we have mucus glands that produce the mucus that we need to secrete on the surface and helps protect against infection and dehydration. That mucus is really important. When we talked about the immune system, we talked about the first and second lines of defense, those innate, non-specific defenses. That mucus all along, or almost entirely along your respiratory tree, is going to have a very important function to help keep debris and microbes and pollens and things out, inside your body, and prevent it from coming inside the body. Right, then we have our paranasal sinuses. Most of us saw those in A&P1 when we did the skeletal system, and we looked at the skull and the different sinuses there. The main ones are the frontal, maxillary, sphenoid, and ethmoid sinuses found in the frontal, maxillary, sphenoid, ethmoid bones. And they, just like the nasal cavities, they warm and moisten air, trap debris in the mucus, lend voice resonance, and they're lined with pseudostratified ciliated columnar epithelium. Okay, then we get into the throat. So we have 3 regions called the nasopharynx, oropharynx, and laryngopharynx. At the base of the nasal passages, or to the posterior aspect, of your nasal passages, is the upper part of your throat that's above your uvula, and that's your nasopharynx, airway passageway that is closed off by the uvula when you're swallowing. It's lined with pseudostratified ciliated columnar epithelial tissue. Also, what's found in the nasopharynx, and I think at some point I'm going to try to add that. Of course, that means I'm going to have to come back and resume this again. But remember that the openings, the eustachian tubes that we looked at in AMP1 when we looked at ear anatomy, and it was one of the locations for elastic cartilage, connects the middle ear to the nasopharynx. Right, so to region the nasopharynx, you have the end of that eustachian tube, and that tube is helping to balance air pressure on both sides of your tympanic membrane. Okay, oropharynx, common passageway for food and air, level with the tongue, right, straight back to the throat. Now, where food goes and air goes, but food because you're going to have stratified squamous epithelial tissue, because food is really coarse. So you're going to have tissue similar to the surface of your body, stratified squamous, the epidermis of your skin, there, so that you don't essentially rip off the tissue. Right. So the food is very coarse, so you have to have stratified squamous there. And then a little farther down from the oropharynx to the entrance point where the epiglottis is, where air can enter into the larynx, that's the laryngopharynx. It too is a common passageway for food and air, site of divergence of the respiratory and digestive systems, because they're just superior to your larynx is going to be the laryngopharynx, but to the posterior aspect is going to be your esophagus. And it too is lined with stratified squamous epithelium. So looking at this picture here, we have the nares in the nasal cavity. We have different, what's called turbinates here, those 3 waves of tissue and bone here that allows air as you breathe it in to swirl around a little bit and have more opportunity to come in contact not only with the olfactory receptors, but the mucus tissue things there, so you can help clean it and warm and moisten it. To the back, that first region of the throat is the nasopharynx. And here I actually identified the opening of the eustachian tube. That's the uvula to the right. Level with the tongue is the oropharynx. Below that is the laryngopharynx. And then into the trachea you go. Into the larynx you go. Okay, so the larynx, we have 3 cartilages found there. The largest is the thyroid cartilage, and that's what houses the vocal cords and the vocal folds. You have the epiglottis just superior to that, elastic cartilage flap that prevents food from entering the airway. So it's going to direct appropriately air into the right tube and food into the right tube. Additional cartilages are the arytenoid and cricoid cartilage that support the vocal folds. Right, function acts as a switching mechanism, like because the epiglottis is considered part of it, to separate food and air and let them pass into the appropriate passageways. And voice production, and the cartilages there help provide a patent airway, keeps it popped open. Right, so looking from what's called anterior to posterior, you're looking right at someone and at their face, so to speak, from the anterior aspect. We have the hyoid bone, and then below that we have the thyroid cartilage, which is very broad on the anterior aspect and narrow on the posterior aspect, especially for lab purposes. The cartilage below that is called the cricoid cartilage. It's very narrow anteriorly and broader posteriorly. And the arytenoid cartilages, they kind of look like horns. You're going to have, it's the only paired cartilage, and that's a good question, and often pops up here or there. It's the only paired cartilage, and it attaches to the vocal folds and to different structures so that you can create different tensions on the vocal folds to create different pitches, of your voice. Below the cricoid cartilage is your trachea. The trachea is composed of what's called these cartilaginous C rings. You can see that there's regions of cartilage with some connective tissue, the white stuff in between. And if we look at the back side, that cartilage doesn't go all the way 360 around it. It actually has just a flexible region on the posterior aspect. So if we could look at the whole model, you'll look at that in lab, it'll indicate that. Okay, so here we have the arytenoid cartilages. Of course, it just shows you one, but if you see the two of them paired, they kind of look like horns. Cricoid cartilage, the vocal folds, and then your tracheal cartilages. Okay, so the trachea, right? Histologically, and we find that bronchi are virtually identical histologically to the trachea, because the bronchi, the right and left main bronchi, are really just a continuation of a larger tube. The trachea, it just has to split, and once it splits at what's called the carina, then we call them bronchi, and they will branch off into smaller and smaller air tube systems, like the cardiovascular system, large arteries to smaller arteries to arterioles, to your capillary beds, where you can have gas exchange and nutrient exchange. The same thing happens in our airway. It starts in a large tube system conveying a lot of air and gases contained within, and then it ultimately has to branch off into very small structures that are essentially where the gas exchange is going to occur, and that's called the alveoli. All right, so the trachea is composed of these layers, quote unquote, the mucosa, submucosa, hyaline cartilage, and adventitia. And the trachea functions as a pathway for air conduction from the larynx into the thoracic cavity, not into the lungs, right, into the cavity. All right, so the mucosa, again, is still just like in the areas of the nasal cavities and the nasopharynx. They are now, because air only will pass through there, is going to be composed of pseudostratified ciliated columnar epithelial tissue. The cilia here directs mucus away from the lungs. It contains a lot of goblet cells contained between these different columnar cells to produce mucus. And there is also mucus glands in the submucosa as well, that are going to produce mucus. So the cilia is designed to extend directly into the lumen, so sort of perpendicular to the trachea. And the cilia are designed to be in an upward singular direction. They don't flip inside and outside, they just be upward. And thus, as the mucus is trapping different particulate and dust and pollen and whatever, it beats upward. So the mucus keeps moving up, through the larynx to either be coughed somehow as spit, so to speak, or sputum, or it may just end up being swallowed, kind of a funky thought, and to go into the esophagus and then just pass down to the stomach and pass through the digestive system. Below the mucosa is the submucosa, where we find a lot of areolar connective tissue for support, and we find a lot of simple cuboidal epithelial tissues because we have a lot of mucus glands there. And glands, 99% of them, are composed of simple cuboidal epithelial tissue. Radiating outward, the next layer is the hyaline cartilage that we just described, those tracheal rings. They help maintain a patent airway, so the airway does not collapse. It's going to be flexible on the backside. And then we have the adventitia. The outer layers of all these organs have some kind of connective tissue, and frequently it's areolar connective tissue, because it allows for stretch in different directions because of all those collagen and elastin fibers. Not that there's a lot of stretch of the trachea, but it's the reason why you can flex your head forward and back and side to side and rotate. The trachea is not a solid tube like piping and plumbing. It has to have some flexibility in it. So that outer connective tissue, again, same functions for virtually everything. It helps support the organ in its place. It's a good tissue to secure blood vessels that are entering and exiting, lymphatic vessels, and nerves. So here, up in the upper left-hand corner, they're showing you the trachea here and the area that they're going to do a cross section. So if we look down on it, we can see the hyaline cartilage in that blue soap bubbly kind of color. Remember, generally when things are in the blue color, it means it's hyaline cartilage. So starting at the lumen, right? So that's the hole in the center. The first layer is the mucosa, and you can see the little hair-like structures there. That's the pseudostratified ciliated columnar epithelial tissue. right? And its basement portion is the darker brownish area. Okay, then deep to that is the pinkier layer, so to speak. That's your submucosa, a lot of areolar connective tissue, and simple cuboidal epithelial tissue. And then we have the cartilage. And then to the outside, we have the adventitia. The outer connective tissue layers, I often don't make you distinguish between whether it's serosa or adventitia. But the way you use that terminology is when you have structures that are in the abdominal pelvic cavity, the outer connective tissue layer is generally referred to as the serosa. And any of these other outer connective tissue layers that are of structures that are not entirely found in the abdominal pelvic cavity, which will include, parts of your kidneys and things as well, it will often be called the adventitia, for those of you who want to know. If we look histologically at that same kind of cross section, with the exception of the most outer connective tissue layer, to the surface we have our pseudostratified ciliated columnar epithelial tissue of the mucosa. Below that, in the lighter pink region, we have our submucosa. And below that, you can see all these mucus glands, all that simple cuboidal epithelial tissue. And then we get to the hyaline cartilage, that soap bubbly kind of appearance with the chondrocytes sitting in the lacunae. Okay, the bronchi. We have, two major regions, the conducting zone and the respiratory zone. And the conducting zone is essentially the larger tube systems conveying air. So in the conducting zone, we're transporting air from the trachea. Now we're going into the lungs because we bifurcated. We have a right and left. And it does so, what's called the carina. It branches down about 25 times until it reaches the terminal bronchioles. Terminal bronchioles divide into respiratory bronchioles. So at that point, those respiratory bronchioles are now part of the respiratory zone. They're microscopic. Respiratory bronchioles terminate in the alveoli or the alveolar sacs. They're clusters of air sacs called alveoli. They kind of looks like grapes, like a stalk of grapes, and the grapes are actually the alveoli. The stalk there would be parts of the conducting zone. All right, so here we have the trachea. At the base, at the point where it divides into a right and left, that's actually called the carina. For those of you, I think they ask you some questions like that if you're doing the standardized eCampus AMP2 lab, or maybe the ones at Seminole or Clearwater. They like to ask that carina, which is that point right here. Then it divides into the bronchi, which are transporting there now into the lungs. They're going to branch off into smaller and smaller and smaller portions. The right lobe does have 3 lobes. That's good to know. And the left lobe only has 2 because the heart's going to be on the left-hand side. You have a superior, middle, and inferior lobe on the right, and a superior and inferior on the left. I believe those are questions they like to ask as well. Okay, the bronchioles. So once we get to the bronchioles that give rise and terminate as the alveoli, so you can see down there at the bottom, it kind of looks like a couple of grapes, a stalk of a few grapes there. The bronchioles, like an arteriole, is going to be capable of bronchoconstriction and dilation. So there's a few things histologically different in a bronchiole than a bronchi, and a bronchi is pretty much, the same as a trachea without some of that outer connective tissue. That's really about it. It's just diameter. All right, so the bronchioles are going to be lined with simple cuboidal epithelial tissue. That's one change. And then instead of having the hyaline cartilage layer, you're going to have smooth muscle. And ding, 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 that's what allows that structure to bronchoconstrict and dilate. You have to have muscle. You have to have something to contract or relax. So all the air conducting portions of the respiratory tree superior to that are supposed to be patent and open and just allow all this air to get in there. But at the bronchioles, we can bronchoconstrict and dilate because we have the smooth muscle there. Thus, they are under autonomic nervous system control, and I put ding, ding. So, this comes down to, okay, now that we're going back to the autonomic nervous system, then you go, okay, sympathetic and parasympathetic. What is the sympathetic response of the bronchioles? It bronchodilates. What is the parasympathetic response? You bronchoconstrict. If we want to bronchoconstrict, we have to send more signals down to the smooth muscle to contract those muscles and narrow the passageway. And if we want it to dilate, then we send fewer signals traveling down there, kind of like what we do with blood vessels, and we allow it to the smooth muscle to relax and become larger in diameter. Okay, the alveoli, its function is gas exchange, bottom line, right? You're going to be composed of a single wall, like a capillary, right, of simple squamous epithelial tissue. And that base is going to have like a little bit of a basement membrane to an adjacent capillary bed. This forms what's called the respiratory, oh, there's a little typo there, I have an extra S there. This forms the respiratory membrane where gas exchange by simple diffusion can occur. All right, so this is it. You have the walls of the alveoli, kind of like the walls of the skin of those grapes I was talking about. That skin there is composed of one single layer of squamous epithelium. On the other side, with just a little bit of connective tissue, it will connect to a capillary, which is also, capillaries are one layer of simple squamous epithelium. So you have two very thin membranes adjacent to each other. And it's that thin membrane like that with those squamous cells with little open windows, gaps in between them, allows diffusion of gases very, very quickly. Remember, the capillaries are going to allow about one red blood cell at a time to pass through there. So you're going to have to gas exchange very, very rapidly. Okay, the alveoli, in addition to the simple squamous epithelium, or I should say, there's two types of cells we find in the layer of the alveoli. We have type 1 cells and type 2 cells. Type 1 cells form the walls of the alveoli. They're simple squamous epithelium. But we also have some type 2 cells there that secrete what's called surfactant. And surfactant is a substance, a chemical, that prevents the alveoli from collapsing by interfering with the surface tension of water. So what it does, right? And also, by the way, we also have some macrophages there. We always want to have some white blood cells there to remove dust and debris and maybe initiate the immune system. Is that surfactant is kind of wet and gooey. And when you exhale, you're going to compress the lungs, from outward to inward. The diaphragm is going to move up. The elastic fibers there that have now been, that were stretched when you took an air in are going to recoil. And so it's going to put pressure on these alveoli to now eject eject air back in the opposite direction the air entered. Air from the alveoli is going to move outward so you can exhale it. So from the alveoli to the bronchioles, to the bronchi, to the trachea, to the pharynx, out the mouth you go, or out the nose you go. This is how you exhale carbon dioxide. Well, when we compress those alveoli and we compress it to eject as much gas as, not as much as we can, but a comfortable amount, you don't want those alveoli to just completely flatten down, like letting air out of a balloon. The walls of the balloon are going to just flop on each other like two little pancakes. Right? So you want to get rid of as much, a certain amount of gas from there, but you don't want to compress it so much that they collapse, essentially. So that surfactant helps prevent the collapsing. We're going to look at these different volumes of air, and your tidal volume, is the air that the quantity of air in milliliters that you take in and out, breathe in, breathe out, breathe in, breathe out, as you're just restfully breathing, at rest, like I am now, even just speaking to you. Right? There's air that you can forcefully, beyond that tidal volume, force your lungs to compress as much as you can and expel as much air as you can. It's kind of uncomfortable. And when you take a breath in, you can actually allow yourself to take an extra large breath in. But even if we take that extra large breath in and we exhale as much as we can and kind of force ourselves to exhale as much as possible, there'll always be a little bit of residual volume of air in the alveoli that helps also prevent those alveoli from just collapsing. So as much as you think you're expelling all the air from your lungs, you're never going to do that unless there's something trauma or something pathological. So that surfactant, is really important for maintaining that. Surfactant generally develops embryologically, about the last trimester, of development, embryological development, and that's why preemies, when, children or babies are born so early, is that they have to have help breathing because, you're still, those last 3 months are really critical for fine tuning, all these different systems. If you could survive on your own after 6 months instead of 9 months of fetal development, then you'd be delivering children, babies at 6 months. So some of these things, this type of surfactant like this, develops later, in fetal development. It's so preemies often have to be on different respirators to help them breathe. Okay, this is a great little picture of the bronchioles to the alveoli. So to me, it kind of looks like a stalk of grapes. In all these little grapes, the alveoli are at the ends of the stalk. The bronchioles, you can see the smooth muscle there wrapping around, similar to what it looked like with the arterioles. They are capable of bronchoconstriction and dilation. And the alveoli, they maybe look like little balloons, I guess you could say. There's some elastic tissue wrapped around those. And we're going to see a picture of the capillary that would be adjacent to it. Right over to the left-hand side here, this is histologically what it would look like. It almost looks like from a distance adipose connective tissue, that kind of honeycomb kind of an appearance, maybe chicken wire kind of an appearance. But when you magnify it, instead of those little, walls of a honeycomb being an adipocyte with a nucleus pushed off to the side, upon further, magnification, you see that those walls there are actually a string of little squamous cells, each having their own nuclei. Right. So here over to the right, you can see they kind of cut into that stalk of different alveoli, and you can see that each chamber, each kind of circular structure there is an alveoli, and it would have its own capillary bed, surrounding it. And further, this is what it looks like. All right, so you have the alveoli here. You have, down to the lower left-hand side, again, they're showing you those elastic fibers, because as we expand the lungs and fill those alveoli and you start to, and it stretches those, and you increase your lung capacity like that, the elastic fibers help recoil and compress and help compress a certain amount around each alveoli so you can exhale away. All right, remember that we come in as blue vessels. Those are going to be the pulmonary arteries because you're transporting carbon dioxide rich blood. It branches off into a capillary bed, and then leaves as pulmonary veins in red. And so don't forget that. Don't be confused or get caught, in any of the lab practicals, questions. Remember, in pulmonary circulation, arteries are blue and veins are red. So that when you branch off into this capillary, now you have a simple squamous epithelium of the capillary to the simple squamous epithelium of the alveoli with that little basement membrane in between. That's what we call, quote unquote, and this gets asked a lot, that is the respiratory membrane. What is the composition of it? This simple squamous of the alveoli, the simple squamous of the capillary, and the basement membrane in between the two. And that allows rapid diffusion of gases down their concentration gradients. Here's another picture of that. So now we really see here in the upper right-hand corner, you see the red blood cells. So that's the capillary. And then to the left of it is the inside, I guess, of the alveoli, you could say. They're so close to one another that oxygen in the alveoli will diffuse into the bloodstream, to the plasma, into the red blood cells, and the carbon dioxide that's being transported in blood will diffuse passively into the alveoli, and then exhale it away. And that is the respiratory membrane. I would know that. Ding, ding, ding. Okay, changes in the respiratory tree histologically. All right, so the trachea has the hyaline cartilages that get replaced by smooth muscles in the bronchiole. So that's one big change. the trachea, the bronchi, all the way till we get to the bronchioles. You're going to have the hyaline cartilage there because you want to keep this airway open. But when you get to the bronchioles, you want to be able to bronchoconstrict and dilate. So you're going to have smooth muscle. The epithelium changes. In the nose, the sinuses, and the nasopharynx, we have the pseudostratified ciliated columnar epithelial tissue, or what we sometimes just refer to as pisket. Oropharynx and laryngopharynx, because they're common pathways for food and air, is composed of stratified squamous epithelium. Then we get into the larynx, into the trachea, into the bronchi. We're back to pisket. The bronchioles are lined by simple cuboidal epithelial tissue, and we terminate in the alveoli as simple squamous epithelium. Smooth muscle found in the bronchioles, affected by epinephrine and norepinephrine, thus bronchoconstrict and dilate. Okay, the lungs, each lung, is in its own cavity and lined with those pleural membranes. The visceral pleura is intimate with the lungs, and the parietal pleura, attaches to the thoracic cavity. And you have the fluid in between, the pleura, the pleural fluid. If we look down into the chest, I show you in the upper left-hand corner, if we take a horizontal or transverse plane cut, then we can see the heart in its cavity. We can see the lungs. We can see the two layers of the pleura, both in white, with then fluid in between them. Okay, the respiration process, right? So normal respiratory rates are 12 to 20 respirations per minute. Pulmonary ventilation is the movement of air into and out of the lungs. And we have different sites of gas exchange. We have external respiration, internal respiration. And then later, we're going to talk a little bit about cellular respiration, which is essentially, remember we said the mitochondria are part of aerobic cellular respiration. That respiration is how gases are used in the cells, essentially, to create ATP. And we have the transport of respiratory, gases. That's the function of the cardiovascular system. All right, so up at the top here, pulmonary ventilation. We have two areas of gas exchange. We have the gas exchange at the lungs, and we have the gas exchange at the capillary levels, deep in the cardiovascular system, deep in the body, which we looked at, when we looked at blood vessels, right? We talked about the hydrostatic pressure out and the oncotic or osmotic draw back in, mainly the function of albumin, and the direction, that as oxygenated blood goes from the arterial to the capillary, enters as red, leaves blue as venules to veins, and so forth. That's our site of internal respiration. External respiration is occurring at the alveoli. Right? So I always think of it as gas exchanging essentially with the external environment. And internal respiration is going to be done way deep internally. So external respiration is a gas exchange in the lungs between the blood and the alveolar air. Internal respiration, gas exchange of the tissues between the capillaries and the cells. Pulmonary ventilation is breathing in and breathing out. It's composed of internal, external respiration. Those are part of the respiratory system, and the transporting of the blood, is the function of the circulatory system. Okay, so external respiration, that gas exchange at the alveoli. Really all you have to do is look at that previous diagram, kind of here. Right? This is what's happening at the capillary. Right? I mean, in the respiratory membrane, in the alveoli, oxygen goes from inside the alveoli, because that's what you just took in as you took a breath in, and carbon dioxide is going to leave the blood and go into the alveoli, exhale, and you eliminate the carbon dioxide. Right. So this is the pulmonary exchange of air into lung flow. The concentration of oxygen in the alveoli, we're going to move from the alveoli, where it's in high concentration, to where oxygen is in low concentration in the blood. Thus it diffuses, because diffusion is a passive process from an area of high concentration to an area of low concentration. So oxygen at the external respiration site goes from the alveoli into the blood. And carbon dioxide goes the opposite direction. Carbon dioxide is in high concentration in the capillaries of the blood, and it's going to diffuse into the alveoli, and then you're able to exhale it. Internal respiration is what we call systemic exchange, blood to the tissues. The flow is reversed as that of the lungs. So now you have oxygenated blood entering into the tissues. Up here at the external respiration, we have deoxygenated blood being pumped from the right ventricle to the lungs to drop off the carbon dioxide and pick up the oxygen. Now we're dropping off the oxygen and picking up the carbon dioxide. So flow is reversed. The concentration of oxygen in the blood is far greater. That's what that greater sign is for, than the tissues. So oxygen diffuses into the cells, or at least out of the blood into an interstitial space and ultimately to cells. The concentration of carbon dioxide is very high in the cells or in these interstitial spaces because cells are working. Their mitochondria is converting glucose with oxygen to ATP, and a byproduct of that is producing all this carbon dioxide. So carbon dioxide moves down its concentration gradient and diffuses into the blood. Now we leave the capillary as veins and venules and veins and larger veins. Thus, they're indicated in blue because they're rich in carbon dioxide. Right, the ventilation process includes, inhalation and exhalation, and that's one cycle. Inhalation, the thoracic cavity volume is going to increase. And in exhalation, the thoracic cavity volume is going to decrease. Right, so when you inhale, these things happen. The diaphragm contracts and drops downward inferiorly. That's why your abdomen rises. Remember that this respiratory effect, is what helps compress and move venous blood back to the, back to the right atrium. And it also is one of the forces that helps keeps lymphatic fluid moving back to the subclavian veins. Your external intercostal muscles will contract and elevate the rib cage and the sternum. Thus, it decreases the pressure in the lungs, and you essentially suck in air. And so the interpulmonary volume increases, the pressure decreases, and air rushes into the lungs. Exhalation is essentially the opposite. This is a passive process. As the rib muscles and the diaphragm relax, then the diaphragm elevates. The ribs drop down because we have atmospheric pressure outside that exceeds the air pressure in the lungs. So the air pressure kind of pushes down on your ribs, and those things compress the lungs, along with, remember, the elastic fibers surround the alveoli are now going to recoil because they were stretched before like a rubber band, and now they're going to recoil. And that creates pressure, in those alveoli. It increases, and essentially we push air back out that air passage way. So the passive process, as the rib, like I said before, the rib muscles and the diaphragm relax, increasing pressure in the lungs and decreasing the volume, because now you're going to squish it and compress it, like squeezing air out of a balloon. Depends on the elasticity of lungs as well. If elastic tissue is damaged, lungs cannot recoil back to normal size. And that, if you understand what occurs normally here, then when that elastic tissue can be broken down by different pathological processes, then your recoil is not going to be significant enough to really allow you to exhale as much carbon dioxide as you should. And the more air that stays in there that's just, full of carbon dioxide, the next breath you take in, you're still not even able to get in as much oxygenated air in there. You're mixing it now all the time with more carbon dioxide than normal. Okay, so this just kind of works you through a diagram as to which muscles are working in which direction and so forth. So during inspiration, right, inspiratory muscles contract, the diaphragm descends, and the rib cages rise. Those are what's called the external intercostal muscles, or to the outer surface, kind of like an external oblique versus an internal oblique. So those external intercostal muscles pull up and on the ribs. They move in what's called a bucket handle kind of a motion, like up and out, and they swing to the right and left, pivoting around the sternum anteriorly and the thoracic vertebra posteriorly. So thoracic cavity volume increases, the pressure in it decreases. Lungs are stretched, interpulmonary volume increases, the pressure decreases, and air flows into the lungs. The reverse happens in expiration. those muscles are going to relax. And sometimes the internal intercostal muscles will help and contract and pull the ribs back down. The elastic fibers recoil, the diaphragm elevates, the thoracic cavity now decreases, the volume decreases, the pressure increases. So now we can push the air out and exhale. Pulmonary ventilation depends on the pressure gradient between atmospheric air and the alveoli. You want the gas, you need to have not only the diffusional pathways helping you, but the difference in pressure gradients helping you as well. Right? Atmospheric pressure, is created by gases in the air. It's about 760 millimeters of mercury. The pressure in the thoracic cavity is slightly less at 756. So here we have a pressure gradient, high to low pressure gradients. Alveolar pressure fluctuates breathing in and out, as we just described. So ventilation produced by the pressure volume there changes in the thoracic cavity during inspiration and exhalation. So what we're saying is that the ventilation, this cycle, is produced by these changes in pressure and volume in the thoracic cavity each time we inhale and exhale. So Boyle's law says that at a constant temperature, the pressure of a gas varies inversely with its volume. What does that mean? It means as one goes up, the other goes down. That's all. For those of you who are chemistry people that use the formula PV equals nRT, it's the same thing, because, N and R, these different, there's constant in there, and it has to do with the moles and how much, pressure and volume you have. But if the volume stays the same and we increase the pressure, then we're going, or if we increase the pressure, then the volume decreases. And if we vice versa, if we increase the volume, the pressure will decrease. So as one goes up, the other goes down. P1V1 means, your initial pressure and volume equals the end, pressure and volume, P2 to V2. Okay, factors that affect ventilation. So this has 4 factors associated with it. Then we're going to talk about 4 factors for diffusion through the respiratory membrane and a few other things. Okay, so these 2 things, if you understand this, and you'll understand different pulmonary pathologies or issues a patient might have, and therefore then what might I expect, the effect of it to be, how would these things affect overall gas exchange kind of at the lungs, and how much air is going to actually get into the lungs. So here we're talking about resistance. That's the first factor that affects air into and out of the whole system. Nasal cavities to the pharynx, to the trachea, so forth and so on. Resistance. Just like resistance for blood, if I increase the resistance along these tube systems, then airflow is going to decrease. Right? Any increase in resistance, maybe excessive mucus production along this pathway. You have a very bad allergy, let's say, and you're producing a lot of mucus. If we decrease resistance, like, open up the passageway and like bronchodilate, then we allow more air to pass through there. So it's just like blood. Lung compliance is the ease that the lung can expand or stretch. So if you can't, take a deep breath in, if your ribs can't move, if your diaphragm can't drop, then you're not going to be able to expand as much as possible. Then, you're not going to be able to get as much airflow into or out of the lungs. Lung elasticity, the ability of lung to recoil. Remember that, those elastic fibers, this is severely impacted by emphysema. Right, so you need to be able to have those elastic fibers stretch and recoil back again. Because if they don't recoil back again, you're not going to move as much carbon dioxide out of those alveoli as you wanted to. And therefore, there's only so much volume in there anyway. It means when you take a breath in, you're not going to get as much oxygenated air in there. Alveolar surface tension forces, surfactant. Remember, if you don't have good surfactant, then those alveoli can collapse. Surfactant reduces the surface tension, which means it resists, folding on itself. It remains kind of patent. Okay, diffusion through the respiratory membrane. So now, these are things are affecting airflow essentially into the point of diffusion and then back out again. Resistance, compliance, elasticity, and alveolar surface tension forces like surfactant. Right, diffusion through the membrane, right? That has other factors associated with it. The respiratory membrane is normally thin and gas exchange is rapid. Factors that enhance diffusion, and thus the opposite of these things will discourage diffusion or prohibit diffusion. Right. So if we want to enhance diffusion, we want the most diffusion of these gases as possible. Right. It will be increased when we have an increased surface area. And that's true for really anything. If we want to have more movement going across the membrane, the more walls we have for exchange to occur, the more surfaces for the exchange to occur, the more diffusion is going to happen. When we get to the digestive system, we look at the same thing. In the small intestine, we have these villi. They're like finger-like projections into the lumen of the small intestine. Why is it there? Because it increases the surface area. Instead of having a nice smooth tube like a hose, the rubber is rather smooth in there. When food passes through there, then your only site of diffusion or absorption of molecules is going to be on that flat surface. But if you could create waves to it, involutions, kind of like hair bristles sticking into the lumen, and on the surface of each hair bristle, you are capable of having molecules move across it, then you're increasing your surface area. And that's what we're talking about here. So we want to be able to maintain all our appropriate alveoli, so we maximize our surface area and we increase diffusion. Okay, the shorter the distance between the layers, between the alveolar wall and the blood vessel wall, a thin respiratory membrane. Look, things diffuse much faster when they're close together, and the distance that they have to pass through, or the thickness they have to pass through, is really, really thin. Right, so it's essentially like a friction, kind of like I guess what you would use for insulation, like your R factors. The better the R factor, the higher the R factor, the less diffusion you have. You keep cold air in and warm air out, and so forth. But when you get them close together and you don't have much insulation, you have a lot of exchange. In lining the walls of your house, you want to have very little diffusion, because that's the whole point of putting air conditioner or heat. When you have an opposing temperature outside. So we want these respiratory membranes to be very thin. You don't want too much fluid on the surface. You don't want to have too much fluid between those two layers or connective tissue between those two, the alveolar wall and the blood vessel. Okay, the greater solubility of gases and a steeper partial pressure gradient, concentration gradients. Okay, so things move faster when they're going from a very high concentration to a very low concentration. The steeper the gradient, the faster molecules move. Simple as that. Ventilation perfusion coupling, and this is something you kind of have to keep in mind going forward as well. We match alveolar ventilation with pulmonary blood perfusion, blood flow reaching the alveoli by vasoconstriction and dilation, and the amount of gas reaching the alveoli by bronchoconstriction and dilation. And what this does is it sends more blood to the better aerated portions of the lungs and less blood to the less aerated portions of the lungs. Right? And then down below it says, conversely, decreased diffusion occurs when you have decreased surface area, increased, diffusional, thicknesses, a rather stable or not very similar concentration gradients that don't, really allow very much diffusion to occur. I mean, it will occur, but it won't occur very quickly, because there's no real difference between the gas concentration on one side of this respiratory membrane versus the other. If they're not very different from one another, then we're not going to have very much diffusion. There's really no need to. But that ventilation perfusion coupling, is a really good thing to keep in mind. And it's really not that complicated. You know that you have these large lungs, 3 lobes in the right, 2 lobes in the left. And when you're just passively, no, it's not passively, but when you're breathing your tidal volume, which is the amount of air casually into and out of the lungs when you're not exercising and breathing, deeply. And when you breathe in and out like that, you don't aerate all the lungs equally, every lobe and every part of your lung. Certain parts will aerate more, like generally toward the upper lobes and things. Okay, so if more air is going to be pumped into and out of certain areas of the lungs and not require your lungs to, fully expand, then there's no need to send a lot of blood to an area where you're not going to have a lot of gas exchange occurring. All right, so you will, you're going to somewhat bronchoconstrict areas that don't need to have a lot of air passing through them, and you're going to vasoconstrict as well. You're going to bronchodilate more to the areas that are easier to kind of expand. It's rather more effortless. And you're going to vasodilate there because we want to encourage blood to travel around the alveoli that are really getting the most turnover of gases. And if you've never noticed it, as you're sitting here thinking about it, is that you kind of see how much of your chest is really moving when you're breathing casually in and out. And if you jump up and down a couple times and then you look at your chest, you can see how much, more expansive your lungs are when you're active. So when you're circulating, you have to take a deep breath in. We're going to bronchodilate and vasodilate to more areas of the lungs. If we're not going to send new gases down there as we inhale, then why send blood there? So we're coupling vasoconstriction dilation with bronchoconstriction and dilation. We want to bronchodilate to the areas of the lungs that are actively taking in gases on a regular basis, and as we're breathing in and out, so that we can, very rapidly allow these gases to diffuse. And in the parts of the lungs that aren't really being aerated, then don't worry about it. Bronchoconstrict, and vasoconstrict there. But when necessary, you will bronchodilate and vasodilate to each of those areas. Okay, homeostatic imbalances. So certain pulmonary diseases drastically reduce alveolar surface area. That's another function or a consequence of emphysema. Instead of having all those independent little grapes on a stalk, they have a tendency to merge with one another. And instead of having 10 little individual grapes, each with a nice, membrane and wall to it, with a capillary bed around it and all those elastic fibers and things, we have maybe 3 large grapes. Well, the walls of the large 3 grapes, are a fraction of what all the walls and surface area is of 10 individual grapes or 10 individual alveoli. And thus you're breaking down or you're reducing the surface area. And when we reduce the surface area, as we said, for diffusion to occur, then you're going to have less opportunity for diffusion. You're going to discourage diffusion. And not only that, emphysema has a tendency to break down those elastic fibers. So not only do you have less surface area for gas exchange to occur, but you have lost the ability to recoil the same way and then expel the gases that are in the lungs. Tumors, mucus, or inflammatory material can also reduce the surface area by blocking gas flow into alveoli. The effective thickness of the respiratory membrane increases dramatically if we have lungs that become waterlogged or edematous, seen in pneumonia or left heart failure. When we start having pulmonary edema, all right, then we have now changed this factor of the number 2, the distance between the layers of the respiratory membrane. If it's thicker, it discourages diffusion. Okay. So blood only circulates through the lungs, for about 0.75 seconds, or I shouldn't say blood, I should say a red blood cell. So it passes through the lungs, in less than a second. That might not be enough time for adequate exchange. The result is body tissues suffer from oxygen deprivation and also the ability to actually get rid of our carbon dioxide. Okay, so the amount of oxygen released from oxyhemoglobin increases with these factors. This is another kind of a topic. So we're talking about diffusion of gases, and now we're kind of like what I call the primal level. Hemoglobin without, when hemoglobin is bound to oxygen, we call it oxyhemoglobin. When it's bound to carbon dioxide, we call it carbaminohemoglobin. So when we have oxygen bound to hemoglobin, we want to drop it off at the tissue level. And there are certain factors in the environment that accentuate that release, kind of like factors that affect diffusion. And this is, diffusion also, to a certain extent. We want to go from areas of high concentration to low. All right, that's fine, but it still has to, hemoglobin still has to let go of that oxygen. Remember, it's bound to the iron molecule in the center of the hemigroup, in the center of each of the quaternary structures of your hemoglobin. So things that affect release, the rapid release of oxygen, think of it this way. It's going to be features or characteristics associated with high like muscular activity. So we said, when your skeletal muscles are working, you're going to be producing a lot of ATP, you're going to be using a lot of oxygen and glucose. The mitochondria are producing all this ATP, and as a consequence, they're producing a lot of carbon dioxide. And that's the carbon dioxide that's being transported back to the lungs so you can exhale it away. Depending on your metabolic activity, how much, your cells are working like that will determine essentially how much carbon dioxide you're producing and how much you have to exhale. That's why you breathe more heavily when you're exercising. Yes, you need to get oxygen in, but you really need to get the carbon dioxide out. Okay, so what are factors that are associated with oxygen release from hemoglobin, or the saturation, of hemoglobin? Well, the concentration of oxygen in carbon dioxide. Hemoglobin, believe it or not, has a higher binding affinity for carbon dioxide than oxygen. What does that mean? It means that hemoglobin would actually rather bind to carbon dioxide than oxygen. And if there's a lot of carbon dioxide around, it's essentially going to kick the oxygen off the hemoglobin. And it will make sense because when we look at the carbonic acid cycle, carbon dioxide becomes rather toxic in the body. It's a waste product. It ultimately increases your hydrogen ions, which decreases your blood pH. And acidic environments, remember, break hydrogen bonds and they affect all your proteins and things. So yes, you need oxygen, but you can survive on a lower oxygen saturation, but you really need to get rid of that carbon dioxide. I mean, you need the oxygen, don't get me wrong, but anyways, hopefully you'll get that point as we progress through here. So as carbon dioxide levels goes up, oxygen gets released from oxyhemoglobin and you drop it. So at tissue levels where your tissues or your skeletal muscles are working really hard, producing all this carbon dioxide, that in and of itself allows or stimulates hemoglobin to drop off the oxygen, which you need there because you need more oxygen in those cells to make more ATP so the muscles can keep working. All right, blood pH. The lower the pH, thus the higher the hydrogen ion concentration, the more oxygen detaches from oxyhemoglobin. And that's kind of goes back to the carbon dioxide point. When we look at this equation, as carbon dioxide goes up, hydrogen ion concentration goes up, the pH value goes down. Right? When you have a lot of metabolic activity, the pH is going to become more acidic, and thus oxygen, readily dissociates from oxyhemoglobin. That's what's called the Bohr effect. Temperature. All right, what happens? What's the temperature when you're actively working out and using your skeletal muscles? Your body temperature goes up, right? Because skeletal muscle contraction generates heat. All right, so along with high activity things, my body gets warm. Higher temperature allows oxygen to dissociate as well. All right, so these kind of should make sense after a while. This not so much, but you just kind of have to, kind of work your way through it, kind of memorize it, so to speak, just the way ventilation and perfusion coupling work together. But the level of what's called 2,3-diphosphoglycerate or biphosphoglycerate, this is a molecule in red blood cells. And as it increases, it modifies. So remember, now we're in the red blood cell and proximal to the hemoglobin. It interacts with the hemoglobin and it allows oxygen to detach from the hemoglobin. So when this 2,3-diphosphoglycerate or biphosphoglycerate levels elevate, kind of like carbon dioxide, then it you encourage the dissociation and the dropping off of oxygen at the tissue level. The Bohr effect is oxygen binding affinity to hemoglobin is inversely related to both pH and to carbon dioxide concentration. Thus, when metabolic activity is high, we're dropping off a lot of oxygen. We don't have to work too hard to do it because the carbon dioxide that's abundant there and higher, the lower the pH, or the higher hydrogen concentration, the lower pH and the higher temperature, as well as the higher amounts of this 2,3-diphosphoglycerol, all encourage hemoglobin to let go of that oxygen and leave it there for the cells. Right. This is one that actually I just saw on, one of those questions, upon review of one of the local universities. I won't say which one, or a quiz that a couple of the nurses that are in the ASN to RN program. So they're working on their bachelor's degree. And they used a diagram like this. And one of the questions was about oxygen dissociation, essentially, and the right shift and the left shift. So the normal level is going to be the thick black line, and we have oxyhemoglobin percent saturation on the vertical axis Y, and oxygen down here, being released or the oxygen in millimeters of mercury, the oxygen pressure, I guess, on the x-axis, right? And so as given those factors of carbon dioxide, temperature, pH, and levels of 2,3-diphosphoglycerol, your normal saturation curve is kind of this S curve, okay? When we have what's called a shift to the right, things that cause a shift to the right is increased temperature, increased 2,3-diphosphoglycerol, increased hydrogen ions, or decreased pH. So it means that when we shift to the right, we're dropping off more oxygen. So the oxygen in the fluid, see down below on the x-axis, it means we're dropping off more oxygen. Right? If we shift to the left, it means we're having more oxygen stay bound to the hemoglobin. So a left shift is going to be the opposite of dropping off the carbon dioxide, things that would discourage oxygen dissociation from hemoglobin. Decreased temperature, decreased 2,3-diphosphoglycerol, decreased hydrogen ions, and decreased carbon dioxide. Increased pH. So they like to use, and these are often the shifts that they refer to. Right, carbon dioxide transport, blood flowing through the capillaries gains carbon dioxide because the tissues have a high concentration of carbon dioxide. They're working, they're doing things, they're metabolically active. They are it's normal for them to produce carbon dioxide. That's why we regularly inhale and exhale to get rid of carbon dioxide. Right, but carbon dioxide is transported in different ways. The least, and it's done so in 3 forms and ultimately has 3 fates. All right, it can either be just as a gas, carbon dioxide dissolved in plasma, which is about 7% of the carbon dioxide. So not much. It's the same with oxygen, there's a certain amount of oxygen and different gases that are just small amounts present just in the plasma, not bound to anything else. The other way it's transported, about a quarter, a little less than 23%, is going to be bound to hemoglobin as carbaminohemoglobin. The primary way we transport carbon dioxide is in the form of a bicarbonate ion, and that's about 70%. And I'll show you how that works in just a second. So a minimal amount in plasma, about a 25, or just think of it, a little less than 25% is going to be bound to hemoglobin, but the majority of it is transported as a bicarbonate ion. And that takes us to what's called the carbonic acid cycle. All right, so this reaction is a reversible reaction. That's why the arrows are going back and forth. If we start at the left and we work to the right, then you'll know that you can go from the right and go back to the left. All right, so if remember that water here, like carbon dioxide plus water is limitless in the body. right? But carbon dioxide normal levels should be around 35 to 45 millimeters of mercury. So it actually has like a blood pH, a normal range. And so a range means it's normal to be between these two values. Go above it, something happens. Go below it, something happens. All right. So if we have carbon dioxide, around 35 to 45 millimeters of mercury. So there's a certain amount available, normally at any point in time. Water is totally abundant. So remember in chemical reactions, is that you often have one limiting portion, of the reactants in a chemical reaction. So, water is limitless, but the amount of carbon dioxide should be a certain value. So the amount of carbon dioxide really will determine how much of our product, carbonic acid, that we can produce, if that makes sense. Right. So let's say if we only have 35 carbon dioxides, but we have 1,000 water molecules, all right, carbon dioxide is the limiting reactant. So if I have 35 carbon dioxides, then I can only maximally produce 35 carbonic acids and thus so many hydrogen and bicarbonate ions. You get that? All right, so water is never going to be the limiting factor, but elevating and depressing or higher or lower amounts of carbon dioxide will determine how much carbonic acid I can produce, H2CO3, and thus with the help of carbonic anhydrase, and actually you don't even really need carbonic anhydrase. That's an enzyme that stimulates this reaction or catalyzes it. Remember, enzymes increase the rate of reactions. This will actually happen without carbonic anhydrase, but it sure helps because enzymes make things go way, way, way faster. All right, so carbon dioxide plus water produces carbonic acid, H2CO3, which then yields a hydrogen ion and a bicarbonate ion. So if you look at carbonic acid, if I take away one H, I'm left with HCO3 instead of H2CO3. And thus, all the parts of these elements in this reaction are all preserved here. So when we say carbon dioxide is transported in different ways, now you see why when we have carbon dioxide, it will ultimately produce the acid, and acids break apart, right? Acids release hydrogen ions. It will release a hydrogen ion and a bicarbonate ion. And so the carbon dioxide is actually here now in the bicarbonate ion. It's about 73% of bicarbonate, or 70% is going to be transported in the form of that bicarbonate ion. It's a reversible reaction. You can go backwards and take bicarbonate plus hydrogen ions to form carbonic acid and let it dissociate into water and carbon dioxide. Okay, so, this carbon dioxide level, I think now you're going to see that, is that if we have a normal respiratory rate of 12 to 20, if I hold my breath and my respiratory rate drops, the carbon dioxide is going to back up into the blood, isn't it? Because you're not going to be able to exhale it away. It's going to be, filling up in the alveoli, but now that the concentration is high in the alveoli and in the blood, you don't have your diffusional pathway anymore. So a lot of that carbon dioxide is going to stay in the blood. Remember, that red blood cell and that plasma is only zipping through the lungs. It's through there in like 0.75 seconds. Right. So if you don't gas exchange, you're going to go back out with the gases that you came in with. All right. All right. So if we decrease our respiratory rate, the carbon dioxide level goes up. We produce more carbonic acid, more hydrogen ions. And when the hydrogen ion concentration goes up, what happens to the pH value? pH value goes down and you become acidic. Now, yes, you're producing these bicarbonate ions, but they're going to be shifted around, into different places. All right. But it's the hydrogen ions that affects the pH, not the bicarbonate ion. Remember, hydrogen ions and hydroxide ions, OH negatives, their proportionality to one another determines pH. That's from chapter 2 in A&P 1. All right, so in systemic capillaries, after bicarbonate is created, it quickly diffuses, from the red blood cells into the plasma and vice versa. So this is what's called a chloride shift. When you have, as the bicarbonate is created, it will then enter into, or actually I should say it goes the opposite way because we're doing this in the red blood cells. It goes from in the red blood cell out to the plasma. And when it leaves, that negative ion leaves the cell, we need to replace it with a chloride ion. So the outrush of bicarbonate from the RBCs is balanced as chloride moves in. That's referred to as the chloride shift. If bicarbonate levels are dropping low in the red blood cell, right, then the opposite happens. Bicarbonate will go from the plasma into the cell, and chloride ions in the cell go out into the plasma. I'm trying to remember. I know they talk about this in the nursing program. Is it really harped upon? Sometimes it's referred back to, and probably because you can have changing levels of chloride ions, in plasma, and what effect that might have, ultimately on blood pH. I don't remember the kind of question that they might have asked, but I do think at some point it becomes relevant in a certain way. I just can't remember exactly how that one of those questions might have gone. If it comes back to me, I'll mention it later. Okay, respiratory control. Well, we have neural mechanisms. The medulla oblongata, generates and modifies our respiratory rate. The pons, remember the pons helps the medulla oblongata in respiratory function. Smooths the respiratory rhythm with the medulla. And then there are other reflexes that influence rate and depth. I mean, just all of a sudden stimulating the sympathetic nervous system, that will do it. So higher brain centers. The hypothalamus activates the sympathetic control. The cerebral cortex can voluntarily adjust the respiratory rate. And what we mean by that is I can say, okay, I want you to hyperventilate right now. Breathe as fast as you can. Yeah, see, that's what they mean about, adjusting your respiratory rate by the cortex, or me asking you to take a breath in and hold it. All right. Chemoreceptors. Remember, we have central and peripheral chemoreceptors that send information, sensory information, to the medulla oblongata. Right. So chemoreceptors will be stimulated with changing levels of carbon dioxide, oxygen, and pH. Those are the most important. Levels of these chemicals are sensed by central chemoreceptors located throughout the brain. And then the peripheral chemoreceptors, remember where the baroreceptors are in the aortic arch and the carotid arteries? We have chemoreceptors there. We said that because you want to be able to monitor the gas content and so forth of blood as it's being ejected from the left ventricle. In the aortic arch, we know what the blood pressure is and the gas content that's going to go out in systemic circulation. And in the carotid arteries, we can evaluate the pressure and gas content of the blood that's going up into the brain, because we need to keep appropriate perfusion of the brain. So we have both central chemoreceptors and peripherals. And then that kind of takes us back to, okay, I always like to keep asking this. What cranial nerve is going to convey that sensory information from those peripheral chemoreceptors? So I might know that. Is it vagus or glossopharyngeal, and from what area? Okay, respiratory control. CO2 is the most potent and the most closely controlled because it produces those hydrogen ions. I mean, it's a waste product. Increased CO2 levels produce more hydrogen ions as per the carbonic acid cycle. And when that happens, if the pH is going down, the response of the medulla oblongata is to increase your respiration rate, so you could blow off some of that carbon dioxide and thus elevate your pH back to a normal range. Decrease carbon dioxide levels, perhaps because you're breathing really, really rapidly, and you're breathing, you're hyperventilating because you're having a panic attack or something, or, you're scared of something. Now you're blowing off too much carbon dioxide. Now you're not producing enough hydrogen ions. And as the hydrogen ion concentration decreases, what happens to pH? It goes up and you become alkalotic. Remember, 7.35 to 7.45 is your normal pH range. So we can adjust the pH by changing our respiratory rates. So what would you do when you're hyperventilating? What do you have like a kid do or something? You breathe into a paper bag. Not a plastic bag. You'll have a different result if you breathe in plastic, but that paper bag, right? Because each time you exhale, you're exhaling some carbon dioxide, but the paper bag keeps some of that, that carbon dioxide in the bag. So when you breathe in, you're breathing back in some of your carbon dioxide, and thus it helps increase your carbon dioxide level, increase your hydrogen ion level, decrease your pH from maybe 7.6 back to 7.44 or 45, back to normal. So you can either hypoventilate and hold your breath for a few seconds, or you can rebreathe, so to speak, like into a paper bag. And, I think most people have seen that used. Okay. Oh, and this comes back and gives you that answer. All right. So from the carotid arteries or the carotid arteries, glossopharyngeal conveys that sensory information. And from the aortic arch, remember, vagus nerve is the only nerve that conveys sensory or motor below the shoulders in the thoracic and abdominal pelvic cavities. All right, FYI, and let me just back up and say, you need to know this carbonic acid cycle even for lecture, because I'm certain, well, more than like, there is a question pool out there, but you should know this reaction, be able to write it out and know what CO2 is carbon dioxide, water is water, H2CO3 is carbonic acid, the hydrogen ion, and the bicarbonate ion, HCO3 with a negative charge. You need to know the charges too. I love those questions. Okay, so here's an FYI. I don't cover a lot of this, but this is part. I probably should ask questions about this. I try not to include too much stuff that isn't reinforced in lab, at least for us here at Gibbs. So, but I'm going to talk about this, so that you understand, what this means, because I know they go into this in nursing to a certain point, not crazy, but to a certain point. Okay, so what is this about in this chart down here? Different degrees of effort in breathing move different volumes of air into and out of the lungs. This measurement of volume is called spirometry. Now, some of you might have even had this kind of a test done. All right, so here we have, lung volume on the vertical axis in Y. We have 0 down at the bottom. Then we have 1,000, 2,000, 3,000, 4, 5, and 6, in milliliters, all right, in milliliters. That's the volume. All right. On the bottom here, it doesn't really matter because we're just measuring into and out of the lungs. Okay, so without looking at all these different arrows and stuff, let's just look at the aqua, the deeper, darker aqua lines in here. So here between, I don't know, it's about 2,400 milliliters to about 2,900 milliliters, right? That aqua line, up and down, like a wave there. That volume in there, the difference between the 29 and about the 24, that's what we call tidal volume. Because as you're somewhat at rest like this and just casually breathing in and out, you're not really taking that much air in and that much air out. And so that's what we call the tidal volume, right? Little in, a little out, little in, a little out. Right. But next, follow that dark teal or aqua line downward, right? See how you have that lower loop, right? That what's happening there is, if I asked you, okay, the next time you go to exhale, try to forcefully exhale as much air as you can from your lungs. So you go, and you try to just force it out. There's a point where you squeeze out as much gas as you can. That's the lower part of the loop there. The distance, between the bottom of your tidal volume to the bottom of that loop there, that's called your expiratory reserve volume. The amount of air you can forcefully exhale beyond tidal volume exhalation. All right. So, so that's what that space represents, from the bottom dotted line here, or the dotted line at the bottom of tidal volume to the dotted line at the bottom of expiratory reserve volume. Okay. All right. So that's your expiratory reserve volume. Now, then I say, okay, just breathe normally. So you go back up here, little wave, that's your tidal volume. Now, what I want you to do when you take another breath in is take in as much air as you can. Take a deep, deep breath. And this, line then peaks upward to, I don't know, 5,800, I guess, up there. And then you come back down again. The difference between the the top of the tidal volume dotted line to the maximum up here That's your inspiratory reserve volume, the amount of air you can forcefully inhale above and beyond the tidal. Okay, that makes sense. When we take the region from the top at the top of inspiratory reserve volume to the bottom of expiratory reserve volume, that's what we call your vital capacity. The amount of volume of air I can forcefully take in and then exhale. That's how much, given my body size, my lung size, and the fact that I do have two lungs. But what if I only have one lung? I don't know. Or if I had some kind of pathology there, these values are going to change. Right? When you have, some kind of pulmonary disease, these values, especially the inspiratory and expiratory reserves volumes are going to change. So the total of all you can take in and all you can exhale is called vital capacity. That amount of air that you never exhale between the lowest of the dotted lines of expiratory volume down to zero, here you can see that's your residual volume. That's the amount of air that stays in your lungs so that your alveoli don't just collapse on themselves. Okay, so there are different, like we said, like capacities. Vital capacity is a good one to know. Right? Hardly anybody really asks you about inspiratory, functional, residual capacities. Total lung capacity, okay, that's just the total, that's just the whole lung. Your inspiratory reserve, your tidal volume, your expiratory reserve, and your residual volume. That tells you exactly the total, gas capability of your lung. All right. But I don't think anybody's going to ask you about inspiratory or functional residual capacity. Vital capacity, maybe, total lung capacity, but the other two, I don't think so. Residual volume, yes. Okay. So by definition, tidal volume is the volume of air moved into and out of your lungs during normal breathing, like now at rest. Inspiratory reserve volume is the volume of air that maximally is inhaled forcefully above and beyond tidal volume. Take a deep breath in as much as you can, as deep as you can. Expiratory reserve volume is the volume of air that can maximally be exhaled forcefully above and beyond that volume and tidal volume. And residual volume is that volume of air that remains all the time and keeps the lungs from collapsing. And this is just another type of graph for the same thing. Depending on the book you use, these will be slightly different. So all right, and that's the end of the respiratory system.